Good afternoon, everybody. I think we can start. I'm Dr. Omboni. I briefly present myself. I'm director of the Italian Institute of Telemedicine, which is fully dedicated to the development of new technologies for chronic disease management, particularly telemedicine, of course, but not only telemedicine. And I am honored to chair this session and to have a presentation after my co-speakers. And we will have 3 presentations dealing with a novel technology for the assessment of arterial stiffness and wave refractions over the 24 hours. This is a promising tool in order to acquire more information on the vascular status of the hypertensive patient in a very easy way. So this is the future of combining blood pressure measurement over the 24 hours with additional parameters which may be useful for screening purposes rather than for diagnosis, which can be done with more complicated tests. We will have 3 presentations covering all the aspects related to the evaluation of central hemodynamics and arterial stiffness, particularly 24-hour assessment, and we will have a discussion at the end. So I would like to introduce the first speaker, which is Professor Jacques Blacher, which is current president of French Society of Hypertension and is chief of hypertension unit at the Hôtel Dieu. His field of interest in research is central hemodynamics and cardiovascular epidemiology. Jacques, please.
Mr. Chairman, dear Stefano, dear friends, dear colleagues, during my slide of disclosures in French, I would like to thank BP Lab to give us the opportunity to have this session dedicated to central hemodynamics. I will begin with arterial stiffness, and there has been a very interesting paper published by a European group some years ago, and in this paper we have the information of the concept of pulse wave velocity, which is nowadays probably the best marker of large artery stiffness. One statement of this paper is that carotid femoral pulse wave velocity is now considered as the gold standard measurement of arterial stiffness. It is a very easy to perform measurement. We need to put one catheter on the carotid artery, one catheter on the femoral artery, to wait for the 2 feet of the blood pressure waves and to measure the distance between the carotid and the femoral artery. There is an issue about the measurement, because sometimes it's very easy to measure the skin distance between the 2 recorded sites. For example, that is a photograph of our chairman, and then for Stefano it is very easy, but some other patients sometimes it is a little bit complicated. There are many studies relating arterial stiffness to cardiovascular risk. And as you can see, it is very interesting to see that all those surveys have been conducted in very different populations. And in all those populations, there were statistical significant relationship between pulse wave velocity and prognosis. The prognosis could be cardiovascular mortality, It could be stroke, it could be MI, it could be all-cause mortality. We performed a study 15 years ago under the direction of Gérard London and Michel Safar. It was dedicated to patients undergoing hemodialysis. And then in those patients, we measured pulse wave velocity, and we waited for years and years, and we tried to see what was the relation between pulse wave velocity divided in tertiles and prognosis. And in terms of overall survival, you can see that patients within the first tertile of pulse wave velocity had a higher, really a better prognosis than patients in the third tertile of pulse wave velocity. Babis Vlachopoulos performed a meta-analysis with all the available data that was published in 2010, and he had those conclusions. That is to say that in terms of total cardiovascular events, cardiovascular mortality, all-cause mortality, as you can see, there was a, let's say, 50% increase in the risk according to one standard deviation of pulse wave velocity. That is to say that for each meter per second increase in pulse wave velocity, he observed an 11% increase in cardiovascular risk. This paper of Mitchell, that was not included in the meta-analysis because it was published just after, is very interesting because probably for the first time it focuses its analysis on added value. That is to say, does pulse wave velocity has added value in terms of cardiovascular mortality or morbidity prediction over and above traditional cardiovascular risk factors. And again, the meta-analysis focusing on this added value that has been published 2 years ago considered that it had an added value. It was focused on aortic pulse wave velocity. And you can see at the end of this paragraph, which was the conclusion of the paper, you can see that it improved the overall 10-year risk classification by 13%. That is to say that, you know, when we classify the patients according to any scale, can be Framingham or score scale, there are some patients that are misclassified. That is to say, in the scale they have low risk, and in real life they have high risk. This misclassification is reduced by using pulse wave velocity. Okay, what about central blood pressure now? When we were younger, it was supposed that blood pressure was decreasing from the central to the peripheral component. That was what I was taught at the university. But the real is the contrary. That is to say that there is a blood pressure amplification. Blood pressure is always higher in the arm than in the aorta, always. And you can see on this meta-analysis of Carmel McNeary, you can see that the higher the age of the patient, the lower the amplification of blood pressure. That is to say that when you are 20 or 30 years of age, the amplification is very high. Then a young hypertensive with 160 here could be 130 here at the level of the aorta. And we really know that it is not only the difference between aorta and brachial artery, it is a difference which is all along the arterial tree. The first paper in the literature showing that there was a relation between central blood pressure and mortality was published by my boss, Michel Safard, and I'm very proud. And again, in a population of patients undergoing hemodialysis, he has showed that the higher the central blood pressure, and here it was the central pulse pressure, systolic minus diastolic, the higher the cardiovascular risk. And again, it's almost the same data, but you can see now it's not the central blood pressure. It is the pulse pressure amplification between aorta and peripheral. And it is exactly the contrary. The higher the amplification here, the lower the cardiovascular risk. There was a very interesting paper published by Piotr Jankowski many years ago, showing that there was a relation between central blood pressure and prognosis, but it is a very interesting paper also because this time it is not a calculated central blood pressure, it is a measured central blood pressure. Piotr put some catheter in the aorta of the patients, and then he measured central blood pressure, and also he measured peripheral blood pressure with a sphygmomanometer. And after adjustments, as you can see, there was a population of 1,000 patients with coronary artery disease. And in terms of complication of the coronary artery disease, you can see that when you put in the explanatory model the invasive ascending aortic blood pressure, the blood pressure remained in the model, but there is no relation between peripheral blood pressure and prognosis in this population. And then, should we take into account central blood pressure or peripheral blood pressure in terms of patient care? It's a very complicated question because of a major statistical problem, which is intercorrelation. We know that systolic and diastolic are highly interconnected. That is to say that when you know the systolic, you know part of the information of the diastolic blood pressure. It is also the same for mean and pulse pressure, and it is the same for peripheral and central blood pressure. And it is not possible to put all these highly intercorrelated parameters in the same statistical model, because after you don't know what stays in the model. And then for that, we need to work on different statistical models. And that has been done by Michel Safard and Bernard Lévy on this paper published, I think, 1 year ago. And finally, they have shown that there were 3 hemodynamic parameters that retained in the models, in the statistical model, where the other hemodynamic parameters were not anymore statistically significant. You can see blood pressure was not, left ventricular mass index was not, but the 3 parameters were central blood pressure, carotid pulse pressure, which was very close to aortic blood pressure. It was pulse wave velocity, and the third one was the amplification between central and peripheral arteries. Then probably that we should, in the future, focus on those 3 parameters. Again, in terms of added predictive value, it's quite difficult, but this paper from Wang shows, as you see, that when you consider central systolic or central pulse pressure, you have a marginal better prediction than when you consider brachial systolic or brachial pulse pressure. In this new meta-analysis, Babis Vlachopoulos have finally shown that there was a marginally better prediction with the central versus the brachial pulse pressure, but he has also shown that there was no difference between central systolic and peripheral systolic. It is to say that when you measure central systolic blood pressure, you do not better in terms of cardiovascular prediction than when you measure peripheral blood pressure. Okay, now we have on the market many devices, and we must consider now that it is time to think about all those devices and to try to compare all those devices. And the concept of measurement is very different from one device to another device. For example, as you know, with the sphygmocore, we calculate central blood pressure from the radial blood pressure curve obtained by tonometry. But we can also determine the central blood pressure from the blood pressure curve which is obtained by a brachial cuff. And I would like to stay 2 minutes on this slide because I think it is a very important slide. On the left, you can see that there are now 3 ways to determine the central, the aortic blood pressure. The first way is to use an applanation tonometry at the site of the carotid artery. And this is quite a direct estimation of central blood pressure. There is a second way is to use a brachial cuff, and from the curve obtained with the brachial cuff, we can estimate the central blood pressure. There are 2 main ways. The first one is by using regression equations, and the second one is by using the second systolic peak. And the third way is the recording of radial blood pressure with a tonometer, and then to determine by a transfer function and an analysis of the blood pressure curve to determine the central blood pressure. But when you have your blood pressure curve, you need to calibrate it with the blood pressure of the patient obtained by brachial cuff. And again, there are 2 ways to calibrate. The first way is to use systolic and diastolic brachial blood pressure, and the second way is to use diastolic and mean blood pressure. And the mean blood pressure is calculated by integration. That is to say, it is not a calculated mean blood pressure, it is a mean blood pressure calculated by integration of all the blood pressure curve on the time of the duration. And there is another issue, which is the error. Because, again, there are 3 types of error. The first error is the error of the tonometer. When you record a blood pressure curve, it's not always the exact blood pressure that is inside the artery. The second error is the error of the sphygmomanometer. We all know that when we measure blood pressure, there is an error. Again, the blood pressure given by the sphygmomanometer is not exactly the real blood pressure inside the artery. And third is the error related to amplification of blood pressure between brachial and radial artery. Because when you calibrate a radial tonometer obtained blood pressure curve with the brachial blood pressure, it is not exactly the same blood pressure here and here because there is again an amplification. Then there are many issues that need to be assessed if we want to go further in cardiovascular risk prediction. My last slides will be on risk reduction strategies because Alain Guérin has performed a very interesting study 15 years ago, and I'm waiting for the sisters of this study. And in this population, we can see that when we decrease mean blood pressure here, and when we decrease arterial stiffness, those patients are still alive at the end of follow-up, but the patients who will die during follow-up, we can decrease blood pressure to these patients, but we are not able to decrease arterial stiffness. Despite the reduction of blood pressure, arterial stiffness does not decrease. There are probably some different effects of different antihypertensive classes on the central blood pressure. As you can see on this paper from Pierre Boutuiri, you have similar blood pressure reduction with amlodipine atenolol and amlodipine plus valsartan at the level of the brachial artery, but there is a different decrease in central pulse pressure with a more profound decrease with valsartan plus amlodipine in comparison with atenolol plus amlodipine. And now we know that atenolol, for a same level of decrease of peripheral blood pressure, has a lower decrease of the central blood pressure. Finally, when we have a look at this meta-analysis of Atanas Protogerou on the different drugs and their ability to decrease central hemodynamic parameters, we can see that it is compelling, convincing for ACE inhibitors, but for all the other drugs, there are very, very few data. And then we need to have more data on the relation between the decrease of peripheral and the decrease of central blood pressure. And then, in conclusion, we can say now that arterial stiffness is an independent predictor of cardiovascular risk. We can say that central blood pressure is an independent predictor of cardiovascular risk. There are still some unresolved issues like intercorrelation, like calibration, like validation, and we need to have the possibility of compare different devices in their ability to predict prognosis in patients. That is to say that we need some very large surveys with different devices, measurements at the entry of the study. Thank you for attention.
Thank you, Jacques, for doing very clearly the point of technologies and current evidence. We can now move to the next speaker, Professor Yulia Kotovskaya. She works in the Department of Cardiology and Clinical Pharmacology of the People's Friendship University of Russia in Moscow. She's working on blood pressure monitoring, arterial stiffness, and central blood pressure. She will talk about a novel technology of 24-hour pulse wave analysis through oscilloscopy. Please.
Okay. Thank you for the introduction. So, dear Chairman, dear colleagues, here's my short disclosure. So, the evolution of the blood pressure measurement techniques encourages the search for the better blood pressure value as predictor for cardiovascular outcomes. And now there is a general consensus that 24-hour ambulatory blood pressure monitoring is a better tool for diagnosis of arterial hypertension and to evaluate cardiovascular risk related to the blood pressure. Central blood pressure is a very important hemodynamic parameter as it reflects the interrelationships between the heart, the aorta, and peripheral circulation. And it's known that aortic systolic pressure is an accurate marker of true pressure load on left ventricle, kidney, and brain. And the results of numerous clinical trials demonstrated that the aortic systolic blood pressure is a better cardiovascular predictor than a conventional peripheral blood pressure measurement. And they also raised a hypothesis that the measurement of peripheral blood pressure is not always the best tool to evaluate the hemodynamic effects of antihypertensive drugs. But when compared to ambulatory blood pressure monitoring of brachial pressure, office central blood pressure demonstrated less predictive value. Thus, the possibility to combine advantages of 24-hour blood pressure monitoring with those that provided by central pressure assessment by the using the devices that offer the estimation of central pressure over 24 hours in addition to the ambulatory blood pressure monitoring seems very attractive. And now the question is whether the clinical value of ambulatory blood pressure monitoring may be further increased by incorporating information on ambulatory central blood pressure. Now we have several techniques to perform non-invasive 24-hour ambulatory monitoring of central blood pressure. And further I will focus my talk on the BPLab Vasotense technology, which historically was the first one in 2007 that provided 24-hour evaluation of key parameters of central pulse wave and arterial stiffness. And actually now this technology is used in the Vasotense registry that is expected to provide first information on the prognostic significance of this new methodology for evaluation arterial function. And also you know that in parallel we have another symposium where AAA study preliminary results are presented, and this technology is also involved in this study. So the difference between the Vasotense technology and other technologies for card-based central pulse wave analysis starts at the technical points about what we as clinicians usually are unaware. Thus, Vasotense technology was initially developed for central pulse wave analysis in addition to 24-hour blood pressure measurement, while in other technologies, central pulse wave analysis was added to office blood pressure measurement. Vasotense technology derives a central pulse wave from the oscillogram that is used for brachial blood pressure measurement, and it means that it's true parallel evaluation of brachial blood pressure and central blood pressure, while other technologies require smaller inflation stage during deflation to derive central blood pressure, and this small pulse wave is used for derivation on central pulse wave in its analysis. So it means that Vasotense technology is independent from the deflation process, but the deflation process is subject to change during the device upgrading. And it means that Vasotense technology may be applicable for any types of blood pressure measurement device if their software allows to store brachial oscillograms. And that was the case for the development of Vasotense technology. You know that it was first integrated into the standard ambulatory blood pressure monitors of BPLab, and they were widely used in Russia since mid-90s, I think. And there was huge archive of brachial oscillograms. They were reanalyzed, and that allowed for manufacturers to develop and improve technology. Accuracy of blood pressure measurement is of key importance, and of course it's very important to know that you use good quality brachial pulse wave to derive central pulse wave, because all those technologies involve for transfer something like a transfer function. And you see that Vasotense technology has internal quality control that consists of visual assessment of brachial pulse wave oscillation curves on the clinical report screen, so you can easily check the quality of brachial pulse wave that is used for further transformation and central pulse wave analysis. So key points of validation of technologies for 24-hour central blood pressure monitoring. First, of course, it's validation of oscillometric modulus for brachial blood pressure measurement. And the second is validation of the measurement of specific parameters like central blood pressure, augmentation index, and pulse wave velocity. I am sure that the audience is well aware about the protocols or validation of oscillometric devices for brachial blood pressure measurement, and you can see that the BPLab device is well validated according to the European standards and the British Hypertension Society protocols, including special populations such as pregnant women and children. Validation of central pulse wave analysis is a very complicated issue. You know that in 2010 the Artery Society released their guidelines for validation of non-invasive hemodynamic measurement devices. It was called Part 2, and it was devoted to the pulse wave velocity. And it was logically to expect that next step will be part 2, which would be devoted to the central blood pressure measurement. But 6 years have come and we still not have any validation protocol for central blood pressure measurement. And this is the issue not only for oscillometric-based central pressure measuring devices, but for all types of devices that are able to measure central blood pressure. And this is clearly illustrates the July issue of Journal of Hypertension that addresses to the issue of accuracy of devices and methods for non-invasive estimation of aortic systolic blood pressure. And also this issue is addressed by the recently published online position statement of the Working Group on Blood Pressure Monitoring and Cardiovascular Variability of the European Society of Hypertension. And this position statement stresses out that the best evidence for the device accuracy is provided by the validation study against invasive aortic blood pressure or against true blood pressure. But those type of studies are very limited because they are limited to special patients population who undergo catheterization for cardiovascular disease diagnosis. So this issue remains actual, and by the way, recently for Vazapen's technology, this type of study was, the results were reported, and the device showed excellent results for aortic systolic blood pressure measurement. But while there is no validation protocol for measurement of the central blood pressure, it's reasonable to use already existing protocols based on the artery guidelines for pulse wave velocity measurement, because many of those devices for pulse wave velocity measurement provide opportunity to measure central blood pressure. And the artery guidelines say that, for example, sphygmocor system may be used as a reference method for pulse wave velocity measurement. And this device is also suitable for central blood pressure validation because it allows direct measurement of aortic blood pressure through tonometry of carotid artery. So, and moreover, this device was used for the clinical trials and demonstrated the values obtained by this device demonstrated prognostic significance. A couple of years ago, our group published this type of study. We followed the artery guidelines in the selection criteria and validation procedure, and the study involved 99 subjects, and the group was well balanced by age, gender, and peripheral blood pressure. The validation procedure was performed by 2 experienced observers. They were blinded to the results obtained from the alternative device. The number and sequence of measurement was as described in the artery guidelines, and we use the brachial blood pressure measurement with BPLAB device for calibration of central pulse wave obtained by the sphygmocor device. So the results and aortic systolic blood pressure, there was a significant correlation between the aortic systolic blood pressure obtained by the 2 methodologies. Blend-Altman analysis indicates good agreement and no systematic bias, and the mean difference between the 2 methods was 2.9 with standard deviation of 3.5 millimeters of mercury. And if we interpret those results from the position of validation protocols for oscillometric brachial blood pressure measurements, it may be graded like the accuracy of class A. So the same picture was for aortic augmentation index, significant correlation, good agreement, no systematic bias, and it's a very interesting data concerning pulse wave velocity. There was significant correlation between pulse wave velocity values obtained by the Vazapen's technology and sphygmocor device, and the difference between the techniques was 0.69 with standard deviation of 1.4. According to the Artery Society gradation, the accuracy of pulse wave velocity measurement by the Vazapen's technology was graded as acceptable. But you can see that Blend-Altman plots indicates that there was more discrepancy between pulse wave velocity values at high pulse wave velocity. Of course, it's an inherent limitation of one-side measurement of pulse wave velocity. Yes, and one should interpret those results with cautious, but the receiver operating characteristic curve shows that the ability of measurement of pulse wave velocity with Vasatest technology allows to determine patients with pulse wave velocity more than 10 meters per second, which is accepted thresholds for target organ damage. And there was rather high sensitivity and specificity of this methodology, so it may be a good screening tool to decide about further evaluation of pulse wave velocity and arterial stiffness in the patient. Thus, in conclusion, my personal thought that is 24-hour ambulatory monitoring of central blood pressure integrated with traditional brachial ambulatory blood pressure extends our opportunity to explore vascular function. It's very promising technology, but of course we have evident progress, we have unresolved issues, but we still have a long way to go. This way is rather steeper, but we are already so far from where we used to be. Thank you very much for your attention.
Thank you. I will make a short overview on results which are available in terms of clinical evidence on 24-hour pulse wave analysis. What we know so far is that brachial blood pressure, aortic pressure, and pulse wave velocity are clearly parameters indicated by current guidelines as useful for better estimating blood pressure control and vascular impairment of the hypertensive patient. Although at the moment only brachial blood pressure and pulse wave velocity are suggested as important parameters to be evaluated. As we have seen in the last presentation, recent advances in technology now allow embedding this kind of evaluation also over the 24 hours. And this means that we have very good potentials for improving the management, the screening of the vascular function in the hypertensive patient in a very easy way. Which are the potential advantages of such an approach? First, all these approaches are easy to use, particularly those cuff-based, so based on oscillometry. These techniques are operator independent. They evaluate arterial stiffness and wave reflection in daily life conditions over a prolonged period of time and repeatedly. They may evaluate activity and sleep, where stiffness and blood pressure may differ substantially. They may be useful to evaluate antihypertensive treatment in daily life condition over a long period of times. And of course, we should not discard the fact that they are affordable. Most of these solutions are cheaper than those used in resting conditions. They may be used in a broader spectrum of patients, and they are potentially useful for screening of particular conditions, let's say hypertension, diabetes, subjects at high cardiovascular risk. But there are also some drawbacks. Those are regarding, in particular, the accuracy. All validation studies of these techniques have been performed at rest, so we don't know if the accuracy proved at rest is maintained in ambulatory condition. There are no standardized validation protocols. We have just seen that there is only one validation protocol for pulse wave velocity. There is a lack of a non-invasive reference gold standard. Most of the studies are used SphygmoCor as a reference, but who knows whether the SphygmoCor is the real good standard, is the better good standard, the best good standard. gold standard. Inter-arterial validation are not feasible, so we cannot validate all these devices with inter-arterial validations. Also because these validations are restricted to particularly healed patients. So most of these studies are done in patients with coronary disease. So we don't know if these validations are really applicable to all other patients. And validation, of course, is device dependent. We don't know if the accuracy proof for one device can be easily applied to another one. Then there is a big issue related to the artifacts. So what's happened about pathway velocity when the patient is performing daily life activities? There are artifacts, and is it pathway analysis accurate in this condition? We don't know. There are limited information on reproducibility, there are no reference values in ambulatory condition, and there is lack of clinical evidence and of outcome-based validation studies. Of course, this is, I tried to depict a very bad scenario, but there is some evidence, of course, and I will try to show this evidence. Briefly, we have for the 24-hour monitoring 3 different techniques. One most popular is based on oscillometry, then we have applanation tonometry, and recently finger photoplatismography. I tried to make an example of the available devices. At the moment we have 7 devices. Most of them, as you can see, are based on oscillometry. One is based on applanation tonometry, and one on finger photoplatismography. Most of them are evaluating classical parameters as pathway velocity, central aortic pressure, and augmentation index, but some of them are proposing some, let's say, weird parameters which indeed has at the moment no clinical application, like QKD for the diasis integra and the past transit time for somnomedics. All of them have been validated for accuracy in blood pressure measurements according to standard protocols. Most of them have been validated for pulse wave analysis with invasive or non-invasive systems. But if you look at the clinical studies, there are some of them having a lot of clinical studies available, some of them they have very few of them. But what is important, that very few studies have been performed in ambulatory conditions. And if we look at the accuracy, this is a meta-analysis I've done, you see that there is quite heterogeneity in the accuracy of these devices. Some devices have good accuracy for some parameters, some others do not have a good accuracy, but there is quite heterogeneity. Accuracy seems to be strongly device dependent. What about reproducibility? Some studies have assessed reproducibility, but most of them have done it in resting condition. So it's completely useless if you want to know if these devices are reproducible in ambulatory condition. We have a couple of studies. This is a study from Portoghero done with mobilograph, and you see that the reproducibility of central blood pressure here is exactly the same as that for brachial blood pressure with similar variation coefficient. Pozokov did a reproducibility study for the BP lab device, looking at the reproducibility of pulse time index of norm, which is the percentage of 24-hour period with pulse velocity within normal range. You see that in normotensive and hypertensive subject, the reproducibility is quite good. What about reference values? We have some data with the BP lab device. Here is a study from Russian group. You see in normotensive subjects, and a quite good sample of normotensive subjects, pulse wave velocity is increasing at increasing age with typical day-night variation. This is the same for aortic blood pressure. This is the same for augmentation index. So we have some reference, again, device dependent. We did also a study with the BP Lab device looking at the 24-hour average values of aortic pressure, passway velocity, and augmentation index between hypertensive and normotensive subjects, and we saw higher values of these parameters in hypertensive subjects. We also look at the relationship between these parameters and 24-hour variability. You know that 24-hour blood pressure variability is an independent marker of morbidity, mortality, and organ damage. So the relationship between blood pressure variability, blood pressure, 24-hour blood pressure, and these values could be particularly interesting. We evaluated variability in two different ways. We weighted standard deviation and average real variability, and you see that aortic blood pressure is larger in patients having larger variability, also after adjustment for the mean blood pressure value. This is true also for passway velocity, but this is not true for augmentation index. So after adjustment, the difference between the two groups for augmentation index disappears. Then there are some studies looking at the relationship between these parameters collected over the 24 hours and organ damage. This is again another famous study from Protoghero, the SAFAR study. You see that the correlation between 24-hour average aortic pressure and left ventricular mass index is quite good, is larger than that for 24-hour brachial systolic blood pressure and for office blood pressure, and in a sensitivity analysis, 24-hour aortic systolic blood pressure is more sensitive than brachial blood pressure. We have also some longitudinal studies. This is a study from Greek researchers. They saw that in patients treated with hemodialysis, there was a progressive increase in all these parameters during interdialytic periods, demonstrating the relationship between arterial stiffness and wave reflection and the renal disease. Also with the BP Lab we have some information. Pozakov did an analysis looking at the correlation between pulse wave velocity collected over the 24 hours and left ventricular mass index. You see there is a correlation for the P-TIN, the index we have seen before, and this correlation is larger than that for the 24-hour mean level. Then we move to a new project which is trying to give some evidence, some clinical evidence on the importance of these parameters. The Vasotens Registry is a large consortium of different countries involved. The objective is to evaluate these parameters over the 24 hours over a period of at least 2 years with repeated recordings, and we try to assess the relationship between changes in blood pressure, arterial stiffness, and cardiac, vascular, renal damage, cardiovascular prognosis, and we will also try to establish normal thresholds for this kind of device. The expected outcomes is to try to promote these kind of technologies for hypertension screening and follow-up. And we would try to favor the use of this device, and why not try to embed these devices in a recommendation of guidelines. This is the system we are using. It's a telemedicine system, it's a platform. Data are collected at the investigator site, are analyzed at the web server, and what is important, we use a software as a service, so the algorithm is embedded in external software, which is fed with the data and returns the results. So it's a kind, we call it an open project for this reason, because any oscillometric tracing can be input in this system to obtain these results. So in conclusion, we may say that 24-hour pulse wave analysis is a potentially promising tool for evaluation of vascular function and damage in daily life conditions, and can be useful to promote early screening in subjects at risk. However, at present we don't have enough clinical evidence on the potential predictive value of these techniques, and we have still a lot to do. In particular, we need to prove the accuracy and the quality of the results we can obtain during the 24 hours. Our vasodens registry may help add some useful information into these regards. Thank you for listening. So I think we have a few minutes for a discussion, even if people are running away. So for the ones staying here, you can come here. So I will first try to raise one general question, which is a very stupid one probably, but shall we rely on these techniques at the moment, or shall we wait for future evidence before moving these techniques in the clinical practice? Maybe some.
My position is that we need to do both, because of course we need to go further in terms of medical research to have better devices, to have better prediction, to work on the best hemodynamic parameters. But I believe that if we do not use those techniques and those devices in the clinical care, it will be much more difficult to go further in terms of medical research. Then it is always the same. It was the same for renal denervation. I think that we need to go further by integrating those techniques in clinical care and, of course, in medical protocols. What is your position?
Yes, I think that it's actually a very promising technique, and of course we should overcome some skepticism about this. But I think that you remember that ambulatory blood pressure monitoring also, there was a very skeptic approach in mid-80s or mid-90s. Yes, and now it's the gold standard to evaluate blood pressure. So we should move on, and without introducing into clinical practice, it's a good idea to use it in ambulatory blood pressure. You know that current international guidelines introduce ambulatory blood pressure monitoring as an important diagnostic tool for arterial hypertension. So even evaluating ambulatory blood pressure, we can have some information about patient vascular function, arterial stiffness, and consider further evaluations of our patients with more complicated technique. So I think it's a good idea, and we just should wait, and we should collect data, of course.
Well, okay, thank you for being here, for staying here, and have a nice day.